Ready. JS, you can make it the stream live on YouTube.
Yes, sir. It is live on YouTube, sir. We can.
Okay. So I am starting. Good evening, postgraduates. Good evening, our respected faculties. Today is the 33rd program of TNOA PG teaching program. An important topic. I need not stress. I need not tell you whether it is important or not. By now, you know it is important. Slipped capital femoral epiphysis, a long case in the exam, can be asked as a long question in the theory exam, and various parts of this slipped capital can be asked as a short notes also. So with this background, we are going to start today. We have two important senior faculties for our program. We are honored to have these faculties as a program. Dr. Sampath is going to moderate this today's session. Dr. Sampath is currently the professor and head of the department, Erode Medical College. He has finished his undergraduation from Tanjavur and post-graduation from Government Rayapata Hospital. He has got plenty of teaching experience, published various papers, as well as attended various conferences. We are pleased to hear you, sir. Now I hand over the proceedings to Dr. Sampath to introduce Dr. Manikandan and go ahead with the presentation. Thank you, sir.
Good evening, everybody. I welcome all for this 33rd TNOA PG teaching program. As already you know, this slip is very, very important for your clinical practice as well as postgraduate examination. And then now I will introduce Dr. Manikandan. Dr. Manikandan is a well-known orthopedic surgeon, and right now he's a professor and head of the department of the Tirunelveli Medical College. Actually, he's doing postgraduate along with me in the Government Rayapata Hospital, and then and he's presented various papers in many national and international journals. And then he's interested in he's doing many cases of arthroplasty, and then complex trauma, and then spine. And then again, he's a PG and UG examiner starting from 2010. And he organized one beautiful TNOA con at Kutralam, very, very superb conference at 2010 as a past president and secretary in Nellai. And he is a guest speaker in various conferences on the state and national level. And just I ask Dr. Manikandan to talk about this slip capital femoral epiphysis.
Thank you, Sampath. Good evening, all. First of all, I thank TNOA for giving this opportunity. So, straight away I am going to my topic. Shall I share my slides?
Yes, sir, you can.
So today's topic is slipped capital femoral epiphysis. So what do you mean by that? What is the definition of the slipped capital femoral epiphysis? It is displacement of a capital femoral epiphysis from the femoral neck through the physis. But this terminology is a misnomer. Why? Because the capital femoral epiphysis maintains its relations with the acetabulum normally, but the neck is displaced anteriorly and also laterally. So the terminology slipped capital femoral epiphysis is a misnomer. The slip can be in any direction. So the posterior is the most common direction. Another one is in the anterior and another one is in the lateral. But anterior and lateral slips are very rare. So regarding the incidence, it is 2 per 1 lakh people. Male predominance, that is 2.5:1. Left hip is more affected than the right, that is 2 times. Age incidence, male is 10 to 16 years. The mean age is the 10.5. Female is 10 to 14 years. So bilateral involvement, that is common in 20 to 40% of the people. Of this, 20% of the people have the contralateral slip on the initial presentation, while the remaining 20% of the people will develop its sleep within 12 to 18 months of the first sleep. So, why you classify? The classification, any fracture or any disease is mainly for an management aspect only. So, this is classified, SCFE is classified based on whether the patient is able to weight bear or not. That is a functional classification, otherwise called a Loders classification, based on the duration of the symptoms, based on the extent of the displacement. What is functional classification? Stable, whether the patient is able to weight bear or not. If the patient is able to weight bear with or without crutches, then you call it as a stable sleep. When the patient is not able to weight bear, even with crutches, then you call it as an unstable sleep. Based on the duration of the symptoms, it is classified into acute, chronic, acute and chronic. So what is acute? The acute is prodromal symptoms like weakness of the limb, groin pain, pain may radiating to the anteromedial aspect of the thigh, or pain in the lower aspect of the thigh or in the knee. So any pain in the knee, in the children's, you always have a suspicion of the hip pathology. So prodromal symptoms for 3 weeks or less. Acute fracture-like symptoms following a minor trauma. So doesn't correlate with the trauma. So radiologically, there is no demonstrable femoral neck remodeling. It can be differentiated from the Salter-Harris type 1 fracture by no prodromal symptoms. The acute slips will have a high incidence of AVN, which is 17 to 47%. Chronic slip, which is the most common form of presentation. Here, the prodromal symptoms for more than 3 weeks. But the classical radiologically, there is a femoral neck remodeling is present, which is the most important thing, differentiate from an acute and a chronic slip. Acute and chronic slip, here also the prodromal symptoms are more than 3 weeks with sudden exacerbation of the pain and patient inability to walk. So radiologically, here also there is a femoral neck remodeling present, but epiphyseal displacement is beyond the remodeling. That is the most important finding in an acute and chronic sleep. What is classification based on the extent of the displacement? The degree of the displacement of the capital femoral epiphysis on the femoral neck based on the head shaft angle. So when the head shaft angle is less than 30 degrees, it is mild, or neck is displaced more than 1/3 of the diameter of the femoral head. Moderate, it is 30 to 60 degrees or 1/3 to half diameter displaced. Severe, more than 60 degrees or 1/3 of the, half of the displacement. So how to measure the head shaft angle? The head shaft angle is measured by a line drawn along the axis of the shaft of the femur. That is the first line. Second line along the base of the physis. Third line, a perpendicular line from the second line, which is intersecting with the first line. So when the contralateral hip is normal, you compare the angle with the normal limb. When it is both is affected, you consider that this 145 degree is in the AP view is as a head shaft angle. A lateral view, it is 10 degree. So based on this head shaft angle, you can have it as a mild, moderate, and severe. Coming to the etiology, It is a multifactorial disorder, no single cause. So the most common cause is an idiopathic. Other causes include mechanical, endocrine, and genetic. Coming to the mechanical causes, three important things. One is thinning of the perichondral ring. What is perichondral ring? It is a fibrous band surrounding the physis, attaching from the epiphysis to the metaphysis, but it doesn't have any attachment with the physis, which most of the time supports the physis. So any weakening of this perichondral ring will lead to a slip. Second one is retroversion of the femoral neck. So the retroversion of the femoral neck will increase the anteroposterior shearing force in the physis. So the slip will occur. Third one is there are increased inclination in the adolescent proximal femoral epiphysis. Physis. There are other conditions which can produce a mechanical etiology like Blount's disease, peroneal spastic flat foot, Leckalve-Perthes disease, rickets, and radiation to the pelvis. Rickets and radiation to the pelvis, which causes softening of the bone, which leads to the mechanical failure. Coming to the endocrine factors, hypothyroid is the most common cause, or hypothyroidism secondary to the panhypopituitarism, intracranial tumors, and hypogonadism. Other causes, primary hyperthyroidism or chronic renal failure cases or secondary renal osteodystrophy secondary to the hyperparathyroidism. Another one is obesity. Coming to the pathology, normally the physis will have a resting zone, proliferative zone, hypertrophic zone. The resting zone will occupy the 60 to 70% of an physis, but hypertrophic zones only occupy the 15 to 30% of the physis. 30%. So when in pathology, the hypertrophic zone occupies the 80% of the physis. So because of disorganized chondrocytes and matrix. So because of this increased hypertrophic zone and weakening of the hypertrophic zone, slip occurs through the hypertrophic zone. In the pre-slip stage, widening and irregularity of the proximal femoral epiphysis happens. Coming to the clinical features, it is pre-slip, stable chronic slip, and unstable acute on chronic slip. In the pre-slip, slight discomfort in groin, usually after activity, and it subsides by rest. Patient complains of weakness in the leg, limping only on exertion. The most consistent positive finding is lack of medial rotation of the hip in extension. This is the most important finding in the free slip. Coming to the stable chronic slip, there is the prodromal symptoms, vague pain from the groin radiating to the anteromedial aspect, pain localized to the lower thigh or knee. Patient will have an limp, that is an antalgic gait, and the limb will be in external rotation. For the movements, flexion, abduction, and internal rotations are restricted. Extension, adduction, and external rotations are exaggerated. The loss of internal rotation on examination and patient complaints of pain at the limit of the internal rotation is the key finding. Positive axis deviation. What is positive axis deviation? It is when you flex the hip and the knee, normally the knee will go to the opposite shoulder. But when in case of slip, if you flex it, it will go to the same side. That is called a positive axis deviation. It also happens in avian. Then another finding is shortening. In unstable acute or acute on chronic sleep, the pain is sudden onset and severe in nature, and it is a fracture-like pain following a minor trauma. Patient is not able to weight bear. This is unstable. So affected limb is in external rotation. There is a moderate shortening. So severe pain from any movement. Coming to the differential diagnosis, the differential diagnoses are Leckalve-Perthes disease, idiopathic chondrolysis, and tuberculosis of the hip. Is any postgraduate available for the question? Hello?
So, yes, sir, I am available, sir.
Right. Introduce yourself.
Sir, I am Dr. Rupesh from Madurai Medical College, doing my final year, sir.
Okay, thank you. So, how will you differentiate a Perthes and a slip?
Sir, in case of Perthes disease, the age group is between 4 to 9 years, sir.
Okay.
Whereas in slip, it is about 10 to 16 years.
So, first decade, second decade, right?
Yeah, sir.
Then?
Sir, in case of SCFE, the patient will be an obese,
Yes.
skeletally immature patient, sir.
Right.
But in case of Perthes, the child may look normal, sir.
Okay.
And in Perthes, there will be a flexion adduction deformity, sir.
Okay.
In case of slip, there is adduction, external rotation, and hyperextension, sir.
Okay.
And clinically, we can differentiate it by, in case of Perthes disease, there will be limb followed by pain, sir. And in patients with SCFE, there will be pain followed by limb, sir.
Okay, very good. How will you differentiate an idiopathic chondrolysis? Do you have any idea about the idiopathic chondrolysis?
No, sir, no idea, sir.
So it is common in second decade, more common in female.
Okay, sir.
So most of the time, the patient will have a severe pain only, that is arthritis-like pain. All the movements are restricted. No other positive finding will be there. By radiologically, you can classify it, differentiate it, right?
Yes, sir.
Tuberculosis of the hip, it can be differentiated mainly by the staging of the tuberculosis.
Yes,
right?
sir.
Right. Thank you.
Thank you.
Coming to the radiology, the AP and true lateral view is mandatory for all the cases, because the lateral view is the best to detect the slip in the early stages, because head is posterior in relation to the neck, so it will be missed on the AP view. In unstable hip, the frog-leg lateral view may increase the deformity, so it is best to be avoided in the unstable hips. Radiological findings in the pre-slip is widening and irregularity of the physis, with the rarefaction in its juxtaepiphyseal portion. The normal, so you must know what is the widening. So the normal width of the physis will be 2.6 to 6 mm. When it is more than 6 mm, you can call it as an pre-slip. So the most important radiological diagnosis is by the Kleins lines and Trithoven sign. What is Kleins line? It is a line drawn along the superior aspect of the neck, and parallel to it, it always intersects the proximal epiphysis at 20% or lateral half. Suppose if it is not intersect, then you can call it as an slip. Diagnosis of the slip will arrive. This sign is called, when it is not intersect, it is called as a Trithovan sign. Another one is metaphyseal Planck sign of steel, which is nothing but you can see there is a crescent-shaped increased density. I am showing there is a crescent-shaped increased density in the metaphyseal region of the neck. It is mainly because of overlapping of the femoral neck over the head. Scam sign or triangle sign of the Kapner. It is a increased density, triangle shaped density in the infromedial aspect of the neck. It is because of overlapping of a neck over the posterior wall of the acetabulum. But in cases of slip, the neck displaced more laterally, so this triangle is altered. Hendon hump, it is in case of chronic slip, because of remodeling, there is bone formation along the superolateral aspect of the femoral neck, which is the main cause for the secondary arthritis, femoroacetabular impingement. All these things are mainly due to the Hendon hump. You can see the Hendon hump here and here. So this is an example of the X-rays. This is an, see here, Glint's line is going up. If you draw it, it never intersects it. Trithovan sign is positive, but there is no signs of remodeling is here. Then you can call it as an acute slip. Here, the head is in center of the physis, but there is an adaptive changes. Here also the Trithovan sign is positive. So this is called chronic slip. Here, there is an remodeling is there, but the neck is displaced beyond the, neck is displaced beyond the head, or head is displaced more. Then we call it as an acute on chronic. So what is the role of CT? The CT will be mainly useful to detect the retroversion of the femoral neck. One is. Second one is accurate measurement of the head shaft angle. Sorry, head shaft angle, not the head neck angle, head shaft angle. But it is not usually recommended. So indication for CT is only 3 conditions to identify the screw penetration. Normally, if you look into the AP and lateral view, you cannot see the exact screw penetration. So the CT will confirm the screw penetration. Second one is because of the overlapping of the head, the physeal closure may not be visualized in the normal X-rays. So to confirm the closure of the physis. Third one is 3D reconstructed images for the correction of the residual deformity during a reconstructive osteotomies. Bone scan, the avian, it is have a decreased uptake. In chondrolysis, it has an increased uptake on both sides of the joint. So, MRI is useful in detecting the early slips, that is the pre-slip, so physeal widening and irregularity. So what is the management? So the management should be considered as orthopedic emergency first. And what are the long-term goals of the treatment? Restoration of the normal functional range of movement, free from pain, avoidance of aseptic necrosis and chondrolysis like complications. So our aim of the management will be reduction and stabilization of the epiphysis to the femoral neck to prevent additional slipping. That is the main aim. Second one is stimulate the early physeal closure. Third one is prevention of complications like avian and chondrolysis. So what are the methods of management? In situ fixation, that may be a percutaneous fixation or mini open fixation. Second one is close reduction followed by fixation. Third one is open reduction, the otherwise called proximal realignment. Fourth one is epiphysiodesis. Fifth, osteotomy and arthroplasty, chelectomy. Each management will have its own indications. So coming to the in situ fixation, the commonest implants used are novel pins, threaded Steinman pin, hip compression screw, and cannulated screw system. So of this, we commonly use the cannulated screw system. For the stable slip, you can use only one screw that is in the center of the epiphysis and perpendicular to the physis. When it is an unstable slip, you have to use two screws to control the rotations. So what is the safe margin for the screw or pin placement? The pin tip should be advanced 8 mm or 1/3 of the femoral head radius only. The distance from the screw for the tip of the head is 7 to 18 mm from the subchondral bone. For the close reduction and pinning, the indications are acute on chronic slip with moderate to severe deformities. In case of mild slips, mild displacement, you do it as an in situ fixation. The close reduction will not be a forcible manipulation. It should be a gentle one, only by an internal rotation. Suppose if the reduction, if the patient comes within 24 hours, you do the gentle reduction. If it is after 24 hours, if the patient comes, you do the gradual reduction by skin traction and internal rotation over 3 to 4 days. The AVN is, the causes of the AVN is not due to the reduction manipulation. It is mainly due to the severity of the injury, unless you do it by a forcible manipulation. So open reduction, when will you do the open reduction? So severe acute or chronic slip, which cannot reduced by the closed manipulation. So even after the reduction, if the degree of the slip will be severe, that is more than 60 degree, then you have to follow the open reduction. The open reduction is by the following a surgical dislocation principles, which preserve the vascularity to the head. So mainly, what is the thing is, you have to osteotomy is the Gann's principle is preserving the blood supply. That is mainly the medial circumflex femoral vessels and lateral epiphyseal vessels. You have to put the incision, lateral approach or Gibson's approach. You have to osteotomize the trochanter and open the capsule in the anterolateral and extend it to the anteroinferior and also to the along the margin of the acetabulum. That is the safe thing to do the dislocations. So what is the indication for an epiphysiodesis? When the slip is severe, so the screw insertion is not possible. Why? Because you have to enter the screw in the center of the head. Suppose if the displacement is more than 50%, so you cannot enter into the center of the epiphysis. So insertion of the screw without exiting the posterior femoral neck and re-entering the capital epiphysis become impossible. That is only in case of severe cases. If you don't want to do it, if you want to do the open reduction or proximal realignment, then you have to go for an epiphysiodesis and osteoporosis or osteopenia, which is weaken the bone. Even whatever the fixation you will do, again you will go for the failure. So you have to go for this. Third one is continuous progression of the slip even after fixation. That is another indication for an epiphysiodesis. In the epiphysiodesis, there is a cortical window made in the neck. Through the window, there is a drilling and curettage done in the physis and autologous bone graft taken from the iliac crust is inserted, which may be combined along with the fixation or not. Suppose if it is an unstable, you have to go for a fixation. If it is a stable one, you don't go for a fixation. So coming to the osteotomy is only for the correction of the residual deformities, mainly after the physial closure, So any primary treatment which gives offset of the femoral neck and head and decreases, or proximal metaphysis become prominent. Because of the prominence of the metaphysis, there is an impingement, osteofemoral impingement, arthritis, everything will develop. So at this time, patient with symptomatic conditions, only you have to go for an residual deformities. If it is an asymptomatic, left undisturbed. The metaphyseal prominence produces femoroacetabular impingement, labral and articular cartilage damage, hip pain, and a degenerative arthritis. So what are all the osteotomies available? When you do it at the subcapital level, it may be called as a dense osteotomy or a fish osteotomy. When you do it at the base of the neck, when it is an intracapsular osteotomy, it is called Kramer osteotomy. When it is extracapsular, it is called Barmada. Intertrochanteric osteotomy may be an Southwick or a Imhauser. So most of the osteotomies will cause avian or secondary compensatory deformities. So secondary compensatory deformity will make it difficult for a THR at a later date. So you have to consider both the things before going for an osteotomy. So more proximal osteotomies like intracapsular osteotomy, like done or fish or Kramer osteotomy, this avian is more common. Extracapsular or intertrochanteric osteotomy will produce a secondary deformities. So what is femoral neck osteotomy, cuneiform osteotomy, which is very close to the physis? It is just distal to the physis. Avian and chondrolysis or incidence is very high. So what is the difference between dense osteotomy and fish osteotomy? Fish osteotomy done through the anterior anterolateral approach. Here the capsule is incised in a H-shaped pattern. But in dense osteotomy, which is done through the lateral approach following a Gaunt's surgical safe dislocation principles. Then base of the neck osteotomy. The two things, one is an intracapsular Kramer and extracapsular Barmada. Intracapsular Kramer osteotomy is mainly indicated in chronic slips with 20-degree or more deformity on either. That is a mild form. Suppose extracapsular osteotomy is for Barmada osteotomy for moderate to severe cases, especially in chronic slips with greater than 30-degree of Kirchhoff angle on lateral radiograph. This is the main indication. So how to do that? Basilar neck osteotomy. Here, the wedge is taken from the antero-superior aspect here and anterior half of the entire neck. The posterior half, you won't take it anything. So once you take it, the width of the osteotomy will be 2/3 of this callus. So 2/3 of the callus, you will take it as the width and take it to the anterior half. Once you have to insert a pin to correct both varus and retroversion. So this pin is inserted to see that this is for correction of the varus. The plane of the insertion of this controlling the neck is, another one is correction of the retroversion. So once you take this wedge, you close it like this and you put a compression screws. So both varus and retroversion both are corrected here. Coming to the intertrochanteric osteotomy, both are basing a same principles. It is a biplanar osteotomy. It is done in two plates. The indication is chronic or healed slips with deformities or head shaft deformities between 30 to 70 degree. So maximum correction you have to do up to 60 degree only. Beyond 60, more than 60, 70 degree, 60 degree means you take it as the 60 as an upper limit. So what is the difference between a Southwick osteotomy and Imhauser osteotomy? The Southwick osteotomy is done at the level of the lesser trochanter. It is taken as an anterolateral wedge. But when it comes to the Imhauser, it is done at the intertrochanteric level. It may be at the anterior or at the lateral wedge. Here, see this. This is the principle for an correction of the Southwick osteotomy. You can see a triangle here. The triangle is, there is 2 degrees. One is 25 degree, another one is 45 degree. This is correction of an retroversion. That is an, if here it is anterolateral edge, this is 25 degree, this is 45 degree. So correction of the flexion, that is retroversion. Here is a lateral wedge which correct the varus. So both the things are corrected by a single osteotomy. If needed, you can do the rotation also. So by a single osteotomy, you can correct both varus, flexion and rotation. So colectomy. What is the indication? It is indicated in a coxa vara and external deformity when it is not severe. It is nothing but removal of the hendon hump. Nothing more than that. Coming to the contralateral slip. So when you see a slip on one side, you have to always have a suspicion that the opposite hip may go for a slip at a initial stage or lateral stage. So you have to assess the opposite hip and find out whether any slip is there or not. If it is an initial presentation, if the slip is there, then you pin it. Suppose if the patient doesn't have the slip, they develop a slip at a later date, that is within 12 to 18 months of this. So how to predict the slip of the contralateral side? So that is by 2 methods. One is modified Oxford score, which is highly predictive of the subsequent slip. What is modified Oxford score? It is based on the 5 ossification centers. One is head, second one is greater trochanter, third one is lesser trochanter, fourth one is triradiate cartilage, then iliac crest, that is an ilium. This is the table. You can calculate the points based on this. So when the modified Oxford score, which is more than 20, the chances of slip, contralateral slip is less. When it is 20 or less than 20, you can see that when it is 16, the contralateral slip is 100%. So based on this, you can calculate whether the contralateral slip will occur or not. Suppose based on this, if it is more than 21 degree, you leave it as such. Less than 20 degree, you have to go for the pinning, prophylactic pinning. So another method, which is called posterior slope angle. What is posterior slope angle? A line drawn along the axis of the femur into the neck. That is the first line A. Second line, that is a line drawn along the base of the physis. That is line B. Third line is perpendicular to the first line. This is measured in the true lateral view. So the angle formed between the second and third line, this is called posterior slope angle. Normally, it will be less than 6 degree. When it is more than 10 degree, 12 degree, it is a predictive of an contralateral slip. Coming to the complication, the most important complication or dreaded complication is avian chondrolysis. Other things are treatment related, that is an implant related complication. Coming to the avian, the incidence will be 10 to 40%. It is more common in the acute slips. It may be with or without the management. Most of the AVNs occurs not due to because of the reduction. It is due to the original trauma, which is caused by the stripping of the periosteum and damage to the lateral epiphyseal vessels. Another cause for the AVN following treatment is multiple pin placement in the posterior superior quadrant, which is also lead to the intraepiphyseal blood supply. The other causes is try to reduce a stable or a chronic slip, or over reduction of the unstable or acute slips, improper pin placements, and following a femoral neck osteotomy. So how to manage? Mild symptomatic, conservative, you wait for under the skeletal maturity. In severe symptoms, you have to do an arthroplasty, no other choice. It may lead to the secondary arthritis. Controlisis. The incidence is 1.5%, more common following a pin penetration or endotrochanteric osteotomy, which may give rise to increased pressure inside the joint. And third one is prolonged immobilization. Clinical features following a fixation of a slip. If a patient developed a continuous pain or a rest pain, always think about a controlisis. So daily activity of daily living is affected, flexion contractures, global restriction of the movements. So what is the diagnosis of the radiological criteria for the controlisis? Loss of more than 50% of the joint space compared to the unaffected side is another one. Another one is joint space is 3 mm or less. That is a radiological finding to confirm that it is in controlisis. Another one is technetium scan. You can take it, the increased uptake in both sides. So here the controlisis symptomatic, conservative management only. If there is an implant penetration, you have to remove the implant penetration. You have to remove the implant, then arthroplasty in severe cases. Coming to the implant related complication, the most important is screw penetration. So what is the rate of screw penetration? Somebody uses a single screw, 2 screws or 3 screws. When there is increased number of screws, the chances of penetration will be high. For a single screw, it is 4.6. 2 screws, it is 20%. For 3 screws, it is 36%. So when you increase the screws, there is higher chances of penetration. Another one is because of the secondary stress concentration at the screw insertion site, there is fracture of the femoral neck or endotrochanteric area. So for the screw related complication, CT is the investigation of the choice. Coming to the other slips, the most common is the posterior slip. So the other slips are lateral slip or anterior slip. Lateral slip is displacement of the superior and posterior aspect. Anterior slip is a reversal of the typical common posterior slip. So in valgus slip, there is a restriction of an adduction and flexion. In the anterior slip, there is a limitation of an extension and external rotation. This is an opposite of a true slip. I never seen a single slip in my 20 years of experience, atypical slips. So this is for just a completion sake, I am telling. Coming to the management, this is an algorithm for a management of the SCFE. So first you have to find out whether the patient is stable or unstable hip. Unstable hip, if the patient is presented within 24 hours or after 24 hours. So stable hip, when it is grade 1 and 2, you always do a in situ fixation. In grade 3, stable hips, if there is, you will not expect any later complication like impingement and arthritis, then you do a in situ fixation. Or suppose if the physis is open, you always go for a proximal realignment, or once the physis closed means you have to go for a neck osteotomy. For unstable hip, so if the patient presents with less than 24 hours, all grades, you have to do a gentle reduction. If the reduction converts the slip into grade 1 or 2, then always goes for a in situ fixation. If the patient having a grade 3, even after the reduction, then you have to go for in situ fixation or proximal realignment or neck osteotomies. For unstable hip, which is presented after 24 hours, for grade 1 and 2, always do a in situ fixation. For grade 3, you do the gradual reduction, that is slow internal rotation. So wait for 3 weeks. If the reduction happens and it is converted into grade 1 and 2, go for a in situ fixation. If it is more than grade 3, if it is grade 3, then go for an in situ or an neck osteotomy. So what is the message? For a stable slip, so do not attempt any reduction. You concentrate only on the stabilization, regardless of their degree of displacement. So reduction should be attempted in all unstable slips and acute and chronic slips. If it is mild, do it in situ fixation. If it is moderate to severe, try to reduce it and stabilize it. So the realignment procedures and the osteotomies should therefore reserved only for patients with restricted range of movement, which impair the function after the fascial closure. So this is a clinical case discussion. Any postgraduate available?
Yes, yes, sir. Rupesh, can I call Rupesh? Yes, Rupesh is available, sir.
Rupesh, can you read the X-ray?
Sir, X-ray of immature skeleton, pelvis, AP view. So in the X-ray, if we draw a clean line, it would not intersect the femoral head, sir.
Yes.
Rithovan sign is positive. And there is a head-on hump, which is seen over the superior of the femoral neck. There is also a metafacial blanch sign of steel present, sir.
Okay.
Then what is the degree of sleep?
Will you call it as what type of sleep? How will you call it as what type of sleep is this?
Sir, sir, I need a frog-leg lateral view to say what kind of sleep is that, sir.
This is a frog-leg lateral view.
So this seems to be a moderate variety, sir.
Yes.
Moderate variety.
Yeah, sir.
Okay. Whether it is an acute or acute and chronic or chronic sleep.
Sir, I need the clinical history and the things to know whether it is.
By seeing the X-ray, I am not going to discuss about it.
Is there any remodeling?
This is a radiology. By radiologically, you can diagnose.
Any remodeling? Is there any radiological appearance of remodeling?
Yes.
Sir, I can't see the. Sir, there is mild remodeling present, sir. It may be an acute on chronic slip, sir.
So it may be an acute on chronic
acute
sleep.
on chronic. Yes, sir.
Okay. That is one thing is, one is mild remodeling is there. So you can call it as an acute sleep also. Sometimes what is happening is, and a remodeling is not much there. Second one is displacement is beyond the neck, right?
Yes, sir.
So you can, because of this, in AP view, you can see some remodeling. Some of the cases of acute sleep develop only after the pre-sleep. So even some pre-sleep stage, patient will have it for the pre-sleep stage for months, occasional exacerbation of the pain. So patient will long standing. Some suddenly developed an acute sleep. So it may be an acute sleep, but based on the remodeling, you can call it as an acute and chronic sleep, right?
Yes, sir.
Okay, what is the management you will suggest?
Sir, I would order blood investigations to rule out any endocrine disorder, sir.
How you are going? Is it going to interfere with your management?
No, sir. No, sir.
Oh, wow. What is the plan? Orthopedic plan only I am asking.
So since it is an acute on chronic sleep,
Okay.
we'll put the patient on traction, sir.
Okay.
And then plan for in situ screw fixation or osteotomy, sir.
Osteotomy.
Hey, you have to plan only one thing.
Sir,
You cannot plan both the things in a single case.
can go for osteotomy in this case, sir.
Osteotomy.
Yes, sir. Since it is a moderate variety.
You won't try for any close reduction? Gradual reduction?
Rotations.
So you can try for a close reduction, sir.
Okay. Once you reduce it, close reduction. So it looks like in the AP view, it looks like what degree? Degree of displacement.
So it looked like mild variety, sir, in AP view.
AP view is mild.
Sir,
See the inferior neck and what is the inferior head? It's mild.
sir, it's a severe variety only, sir.
It is
Moderate. Severe.
It's not a moderate, it is a severe.
Severe.
Right?
Yes, sir.
Suppose, can you do an in situ fixation in this?
So we can try after a close reduction, sir.
So suppose if you try the close reduction.
Yes, sir.
So if it is converted into grade 1 or grade 2, that is the mild or moderate.
We can go for in situ fixation. Then.
So suppose it is not possible to reduce it.
So even then we can try in situ fixation, sir.
How? So what is the principle of an in situ fixation?
Preventing further slip, sir.
Okay. What is the screw? How the screw has to be in the epiphysis?
So screw should be perpendicular to the physis, sir.
Okay. In the epiphysis?
It should be in the center of the head, sir.
So is it possible in this displacement, can you able to introduce the screw in the center of the displacement?
No, sir. Not possible, sir.
Then in situ fixation, it is possible.
No, sir.
Then what will you do?
Can go for osteotomy, sir.
Osteotomy. Osteotomy?
Yes, sir.
So what type of osteotomy?
Sir, most commonly done is modified Dunn's osteotomy, sir.
Modified Dunn's osteotomy.
Yes, sir. The subcapital realignment of epiphysis.
Okay. Modified Dunn's osteotomy you are planning.
Yes, sir.
Okay. Right. Any other postgraduate is available?
Yes, Dr. Hariharan is available. What the thing is, I couldn't make him as he is muted. Hariharan, JS available?
Yes, sir, I'm available. I'll
Make Dr. Hariharan as a co-host. Dr. D. Hariharan. So wait for a few minutes, sir. He will be available.
No problem, sir.
done, sir.
Hello,
Done,
sir.
sir.
Then Dr. Hariharan?
Sir, I'm Hariharan, sir.
Yes.
Yes,
Sir, your
sir.
class.
Hello.
Yes, sir. Sir, good evening, sir. Sir,
Good evening. Introduce yourself.
sir, I am Dr. Hariharan, final year ortho PG from KP with Trichy, sir.
Trichy. Okay.
Yes, sir.
Can you read the X-ray?
Yes, sir. So this is a plain X-ray of pelvis with bilateral hip of a skeletally mature patient showing bilateral hips with left side hip pathology, sir. There is on drawing a clean line, Trethovan sign is positive on the left side, sir, and there is a coxa vara on the left side, sir.
Okay.
And there is also increased sclerosis seen in the proximal femoral metaphysis, sir.
Okay.
The joint appears to be normal, sir.
Okay. What about the physis? Is closed or not?
Sir, physis is still open, sir.
Okay. So,
Sir,
your diagnosis, complete your diagnosis. Patient is weight bearing.
yes, sir. Sir, it's a chronic type of SCFE, sir.
Chronic only. You complete your diagnosis.
Sir, chronic type SCFE with coxa varas.
I put the lateral X-ray also.
Sir, in the acetabulum, there are a few sclerotic changes present, sir. So going for chondrolysis.
So, joint spaces looks,
No.
it's not a chondrolysis. Maybe X-ray view, maybe not. But clinically, patient doesn't have evidence of chondrolysis.
Sir, it's acute on chronics.
Acute on chronic. Why you are saying it is an acute on chronic? Already I told you the patient is weight bearing. When the patient is weight bearing means what it is?
Means weight bearing means it's a chronic, sir.
Only chronic. If the patient weight bear in acute or acute on chronic?
Sir,
Will the patient weight bear in acute or acute on chronic?
sir, in acute on chronic only he will be weight bearing, sir.
Acute or chronic, the patient will weight bear.
It's a chronic.
Sir, it must be a stable type.
Most commonly, the patient weight bearing means it is a chronic.
Okay, sir.
Acute on chronic, the patient will have a severe pain and other things. Patient will have a prodromal symptoms for 3 weeks, more than 3 weeks. But acute fracture-like pain will comes after the acute sleep.
Yes, sir.
So diagnosis, complete your diagnosis.
Chronic variety of slipped capital femoral epiphysis, sir.
So what amount of displacement is there? Looks like.
Sir, frog-like lateral views.
I showed it.
Sir, there is mild displacement only, sir.
So complete your diagnosis.
Sir, stable type of SCFE, sir. Stable type chronic stable chronic variety, sir.
Stable, chronic, mild.
Mild SCFE.
You have to include all these things.
Yes,
By your diagnosis, I can understand what the patient's condition is.
okay, sir.
So chronic,
mild, chronic mild stable type of SCFE.
right. What is the management you will suggest for this patient?
Sir, since it's a chronic variety, mild type, we'll go with in situ pinning, sir. In situ pinning and in situ screw fixation, sir.
Okay. Will you attempt any other move, any other procedure?
Sir, in situ pinning is sufficient, sir.
Okay.
There are no callus and all.
Okay. Thank you. So
Thank you, sir.
There's any other postgraduate?
Any postgraduate who is willing to take part, please type your name in the chat box. Veeramani has raised a hand. Veeramani, Dr. Veeramani. JS?
Yes, I'll unmute Dr. Veeramani, sir.
Dr. Veeramani, yes.
Yes,
Veeramani, are you available? Dr.
Sir, I already
Veeramani?
asked Veeramani sir to unmute.
Sir, available, sir.
Yeah, Veeramani is available.
Hello.
Sir, good evening,
You
sir.
can ask.
Good evening, Veeramani. So introduce yourself.
Sir, I'm Dr. Veeramani from Government Rayapeta Hospital, final year orthopedics, sir.
Oh, my parent institute. Okay.
What happened?
Hello.
Yes, sir. You can go. No problem.
Veeramani, sorry for the poor quality X-ray.
Sir, no problem, sir.
See the X-ray, the AP view. This is the lateral view.
So, okay, sir. Sir, it's X-ray pelvis with both hip. It is so it's a skeletally immature individual showing both femoral head and bilateral femoral head and bilateral femoral shaft, sir. With sir,
Yes.
Yes.
sir. On X-ray view, there is a spatial remodeling is present, sir, with slipped capital femoral epiphysis of in according to the Southwick angle, it will be more than 60 degrees, sir. I think it will in a severe type. It is chronic SCFE, sir, because the remodeling is present, with the bed and hump is present, and also with femoroacetabular impingement also present, sir. Cam type impingement also present on the right side.
Patient not weight bearing.
Sir?
Patient is not weight bearing.
Sir, it was the diagnosis was unstable chronic slipped capital femoral epiphysis, sir.
With
Sir? With this severe type, sir.
Severe type. Right?
Yes, sir.
Sorry. So, what is the management you will suggest?
Sir, I will go for Gans osteotomy, safe surgical dislocation of the hip, sir.
Yes.
With chondroplasty, sir. With cartilage repair, sir. Mainly go for chondroplasty. With followed by, if there is able to reduce, we will do open adduction with a screw fixation. Or if it is not able to reduce, with in situ, we will fix and come, sir.
In situ fixation is possible in this case.
Sir, the fix, sir.
You said it is not, if I am not able to reduce it, in situ fixation is possible.
Sir, in situ fixation is not possible, sir. But while dislocating, if the physis will be reduced or not reduced, we will check, sir. If there is reduced, we will fix and through the Gans osteotomy approach, sir. Gans osteotomy and safe surgical dislocation.
If it is not reduced, what will you do?
Sir? Sir?
Suppose if it is not reduced, what will you do?
Sir, I will go for endocrine osteotomy, corrective osteotomy, sir.
Already you done your safe surgical dislocation. Why can't you go for a dense osteotomy? Already you done it. Open it.
Okay, sir.
So you
Sir,
want to
then
remove it again. Go for endocrine osteotomy.
Sir, no, sir. Then removal of the hump and alignment of the physis to the neck, sir. Then try to alignment of physis to the neck.
So
then
proximal realignment, you want to try it.
Sir?
Proximal realignment, you want to try it.
Yes, sir. I want to try it, and removal of the hump should be done, sir.
Okay. Sorry. I'll show previous X-rays. Yes. In this X-ray, can you predict the contralateral slip?
Sir, contralateral slip. Sir, the cleansed line. Sir, the cleansed line. It should not cross more than 20% of the lateral femoral head. I think able to, sir, not able to clearly see, but the cleansed line, the Triton sign only positive on the right side. So I think the early slip is there on right side, sir.
About, can you predict the contralateral slip? Now it is not a slip in the right side, right?
Yes, sir. Now not a slip in the right side, sir.
Right. Okay, I'm accepting that. Why my question is, can you able to predict the slip? Will the slip occurs at a later date or not?
Sir, I will go for MRI, sir. If there is it's able the contralateral slip will occur or not. I will go for MRI, sir. But this available X-ray I can't conclude, sir.
So that is why I told you this one. How will you predict the contralateral slip?
Sir, that you told, sir, the Oxford score, sir, and posterior slope angle.
Posterior slope angle. So here see that the triradiate cartilage is almost fused.
Yes, sir.
Able to see it. Triradiate cartilage almost fused. Are able to see it, right?
Oh, yes, sir. The triradiate cartilage is almost fused on.
So most of the time, this is the one more predictive point, that triradiate cartilage is fused. The chances of slippage of the contralateral slip is very less. So there is no need of prophylactic pinning.
Yes, sir.
That is the point I want to tell you, right?
Oh, okay, sir. Okay, sir.
Thank you.
Thank you, sir. Thank you.
So thank you everybody for watching this.
Sampath sir, there are a few questions in the chat box, sir. You can ask the faculty.
Ask the questions.
Any questions?
Yes, sir. One Dr. Thomas Charles has asked, what is reverse slip? What is reverse? What is reverse slip? Question is, what is
reverse slip? It is the reversal of the common slip.
Okay, that is one question, sir. Other one is
from Rupesh Mudurai. What's the cause for knee pain in SCFE? That is
always the radiate is both nerve supply of the hip and knee is common. So referred pain.
Yeah. Any other questions?
Sir, is there any role for a posterior approach in SCFE, sir? SCFE, can we ever try posteriorly?
Mainly a Gant safe surgery. If you want to approach the neck, it is better to go for a Gant surgical dislocation procedure by lateral approach only. So posteriorly, if you go for it, there are two things to happen. There are posterior periosteum is most important thing, because it is carrying the lateral epiphyseal vessels. So when you incise it, you damage the lateral epiphyseal vessels and ending in a AV. So posterior approach should be avoided.
And how many pins to be used?
How many pins for?
That is a single or multiple pins.
Stable hips always use the single pin. Then it is unstable hip, always use the 2 pins.
Okay.
But when you are afraid of all these things, you always use the safe 2 pins.
Other which is better, screw or pin, which is better?
So I personally asking me means I always use for 2 screws.
That is a cannulated screws, no?
I always go for a 2 screws.
Like cannulated screws are.
Cannulated screws.
Okay. What is the diameter of this cannulated screw? Which diameter?
So normally 7 mm cannulated.
Okay.
Preferably a titanium screw, sir.
So only thing is the screw, because the screw has to be held in the position up to the physeal closure.
Yeah.
If the screw threads is not in a reverse cutting manner, it is difficult to remove the screws. Okay. So always use the screws with having a reverse cutting.
And then how to prevent the screw head penetration?
Not for this one. For removal makes easier. Otherwise, the removal is very difficult.
Okay. Now, what are the precautions?
Because of that, somebody use a fully threaded screw also. All right.
One question. What are the precautions to avoid screw penetration? So
that is why I told you. That is, you have to enter the epiphysis perpendicular to the physis, and only up to the 1/3 of the diameter of the head should be purchased. You have minimum of 7 to 7 mm subchondral bone clearance, minimum.
Okay.
So depending upon the epiphyseal size, it may vary up to 16 mm.
Okay. And what will you do if there is any accidental penetration?
So it is penetration means it is gone, it is out of our hand. So you have to wait and watch, you have to reverse the screw and wait and watch until the hydrolysis happens or not.
Good, good, super.
They can't do anything at this stage. Once you crossed it, so most of the problem is most of the surgeons crosses the epiphysis and fix it into the acetabulum.
Oh yeah.
So that itself produces a chondrolysis.
And then one more question from Veeramani, Dr. Veeramani.
Yes.
A case of neglected slip with arthritis at 17 years. What's the order of management?
What's the age?
17 years.
17 years.
Neglected sleep.
17 years.
Yeah.
If the patient is able to lead an activity of daily living, I can wait and watch. Suppose if the patient is not able to do an activity of living without much disturbance, means I will wait until the skeletal maturity. Suppose patient not able to, patient is in slide or a severe pain, then I have to go for an arthroplasty, even at the younger age group. So even 15 years up to younger age was done the replacements.
Okay. And he's also asking one more question. After screw fixation, what's the ideal time for weight bearing?
What the textbook says.
Post-operative.
What the textbook says is, if the chronic stable slips, you can touch this toe-touch weight bearing immediately after that, and weight bearing as the patient tolerant, because already it is a stable one.
Yeah.
Unstable hips, you always wait up to 6 weeks, minimum of 6 weeks.
Okay.
Any other questions?
It's a very good discussion. It's very useful for pages.
Yes, yes, sir.
Adolescent Kapsavara.
Yes, sir.
Any questions?
So, no, sir. Almost everything you have answered, sir, in your presentation, as well as PGs have asked the doubt, cleared the doubts in the chat box.
Okay.
Okay, sir. So, on behalf of TNOA, as well as our postgraduates, I thank our faculty, Professor Manikandan, for the detailed and excellent lecture on the slip capital epiphysis. This particular presentation is also available on the YouTube. Before going for examination, you can also review it and refresh your knowledge as well as memories, so that you can answer the questions very confidently in the exam. I thank our Professor Sampath for coordinating this session and make the sessions a lively one. I thank you very much, sir. I thank our PGs, Dr. Rupesh, Dr. Hariharan, Dr. Veeramani, for participating and make these sessions more interactive. Thank Alembic JS and Ramesh Kumar for sponsoring this event. Thank you, TNOA. On behalf of all of you, I thank you. Thank you very much, sir.
Thank you. Thank you.
Thank you.